So my name's Anne Wright. I am a consultant who has a joint appointment. I run a tertiary regional bladder department at the Evelina, where I tend to see more top-end bladder difficulties. And I'm also a community pediatrician 1 day a week, so that I continue to see children with neurodevelopmental issues, and also run the bladder and bowel clinic. So I actually feel very fortunate because I get to see the entire range of bladder bowel dysfunction, which is really, really interesting. Hopefully I can get through. There's a lot of material. Hopefully we can get through some of it anyhow. Hopefully this will be interesting to you, because I think that in terms of bladder bowel dysfunction, it's not something that's concentrated on a lot. It's not something that we formally taught. And the science of bladder bowel dysfunction in pediatrics is probably only about 30 years old. So it's relatively new. So my first slide, I've learned that there's a little bit of a delay between me doing this on my computer and it coming up on the teaching, but hopefully the next slide is going to come up. Is it? Doesn't appear to be. Let me just have a look. Okay, oh, there we go. Okay, so a reminder about bladders and bowels. So we've got these wonderful organs of elimination located in our pelvis. And a bit like the plumbing in our houses, it just quietly gets on with the business of eliminatory function, hopefully without causing any difficulty and any problems. So because it's not particularly glamorous or social, we tend to often just ignore bladder bowel dysfunction, assuming that it's all going to work fine. And it's a little bit like your house until the plumbing goes wrong. That's my EPR going, sorry. It's going to turn off in a minute. I should have closed it down, sorry. So until something goes wrong, you don't really become aware of it. So of course the bladder is the eliminatory organ for liquid, and the bowel is the eliminatory organ for waste. They are co-located, and interestingly, they share the same neurological basis and the same embryological tissues arising from the same place. The bladder's primary function is to store, and the clue with that is in the shape of the bladder. It's round and it blows up and it stores. But storage is what it does 99% of the time, but of course voiding is very important as well. What I'm not sure if you appreciate about the bladder is, like most round muscular organs, it generates a pressure. And bladder pressures are very important with regards to the upper tracts, the kidneys that produce urine. And we don't want those pressures to be obstructive. And basically the kidneys are happy with the pressure in the bladder of somewhere between 10 to 15 centimeters of water. So you can see here that during filling, the pressure in the bladder should be very low, less than 10 centimeters of water. And then we get the feeling of needing to wee, and the bladder voids, generates a momentary pressure. In girls up to about 60, in boys can be higher than that, and then back to normal. And this way the bladder doesn't cause any pressure, undue obstruction to the kidneys. This is just to show you that we used to think as babies the bladder and bowel work just by a reflex spinal arc into the sacral spine and out again. Actually, we know that the frontal cortex the pontine micturition center, and the whole spinal cord is involved in modulating bladder and bowel. And therein lies a lot of the issue with regards to dysfunction. So any damage to this entire neural axis, actual damage, for example, myelomeningocele or transverse myelitis or a tumor or injury to your spinal cord, or indeed brain dysfunction. And that includes, there are lots of loops that involve brain and bladder and bowel function in the brain. And conditions such as ADHD and autism can actually affect these loops and end up with bladder bowel dysfunction. So that's the purpose of showing you this neural axis that controls both. The consequences, of course, of disruption in this axis is that your bladder and bowel don't work properly and you can end up incontinent. And very importantly, with the bladder, you can get very raised bladder pressures, which can slowly but surely knock off your kidneys over time. So that's why, particularly with neurogenic bladders, we look after them extremely carefully from the word go. This afternoon, I don't want to talk about pathological dysfunction in bladder or bowel. We're going to talk about functional incontinence. And the International Children's Continence Society classifies incontinence in children into nocturnal enuresis, that's bedwetting, daytime urinary incontinence. Please don't use that term diurnal enuresis anymore. That's old-fashioned and not used anymore. And fecal incontinence. And the subclassification causes of these causes of incontinence are listed here. And we're going to try and whiz through some of these. And of course, fecal incontinence is the least common, then daytime urinary incontinence, and enuresis is by far the most common. But of course, the order in which we treat these different incontinences is the opposite way around. So if there's any constipation, we treat that first, then we treat the daytime urinary incontinence, and finally we treat the enuresis. And that, of course, is the order of toilet training. That's the order in which we achieve continence at toilet training. It's often quite frustrating for families that arrive with nocturnal enuresis, and in fact you find out that they're constipated and they've got some daytime wetting. You have to persuade them to go back to deal with these other two issues first. So let's think a little bit about enuresis. Lots of community clinics run enuresis clinics, and our thinking about enuresis has changed quite significantly over the last 30 years. So if we think about a structure in an enuresis clinic, and what are the things that you're going to need to elicit, you need to elicit some basics. Age is fairly basic. Frequency of wetting, very important in terms of how common is the wetting occurring and whether it's primary or secondary. And other classifications, that's going to inform your prognosis. So that's a really good thing, and I'll show you how that's going to inform your prognosis. With regards to underlying causes of wetting, you want to know the characteristics of the nighttime wetting. And we'll have a look at that in due course. But you also, very importantly, want to know if there's any daytime lower urinary tract symptoms. So that means that you've got to really understand and know about how children's bladders work to elicit whether there are any abnormalities by day, because this indicates a bladder dysfunction as a cause. Then you want to know about pragmatics. There are lots of people who are not particularly pragmatic about nighttime wetting. And then you want to know about confounders. These confounders can complicate and frustrate treatment, so you want to recognize them and deal with them. Constipation, we've already mentioned. Sleep apnea is one, so always ask about snoring at nighttime. We know that if you're having significant obstructive sleep apnea, you're going to wet the bed. And often there are quite a few large series now about tonsilloadenoidectomy causing an improvement in enuresis. So let's think about a case. This is just, we're after lunch, and I know that actually, well, I find it quite hard to concentrate in these virtual teaching sessions. So please read about Alan. He's an 11-year-old boy. This is a kind of very standard history taking. They've pitched up at 11. Actually, the motivator is that he's about to go on a school camp. That, of course, year 6, that's really worrying him. And they're a fairly sensible family. I see that someone can't see the slides. I am seeing the right slide. I don't know, Katie, if you can just tell me whether
I'm seeing the current slide. Is anyone else having that problem? It might be your end, AF. Yeah, I think we can see the current slide.
Which slide, Katie?
I can see the case study slide, the 11-year-old boy, Alan.
Okay, good.
As part unit, so it might just be that user. I don't know.
That particular computer. Okay. Okay. All right. So good. So Alan, he's got a sensible mother. She's tried fluid restriction before bed. She's tried reward charts, and she's tried to wake him. But he's a deep sleeper. He used to have little accidents before when younger, but not anymore. And there's a lot of friction between, sorry, I have now, can you still see these slides, everybody? For some reason, I have now got.
I think, let me just double check. I think we might have made, sorry, somehow AF was made presenter.
Okay, fine. Oh, good. So there we go. Is that better again?
Yes, perfect.
Good. So he's been to his GP and he's on some desmopressin. And he's having some dry nappies, but he's still wet. Doesn't have any side effects. And mother also tried the Enuresis alarm last year, and that didn't work because he couldn't wake. So these are common questions from mother. Mother just wants to know when he's going to grow out of this. Is puberty going to help? That's the big hope for mothers. And Alan's pretty monosyllabic, pretty embarrassed, and he just hates wearing nappies and wants to know what's going to happen for the camp. Okay, so I'm trying to move my slides on. It's a bit of a delay. Okay, so I'm going to just tell you what the next slide says. I want you all to think about, we're all pediatricians and we're all nice to people. So we want to contextualize for Alan his bedwetting. And there are a number of statements that I want you to read, and just think there's one correct statement, and I want you to decide which statement you're going to go with. Statement A, 5% of 10-year-olds wet the bed, and it is more common in boys. Statement B, Ben's chances of spontaneously improving are good. There's an annual spontaneous cure rate of 16%. Statement C, very few children wet the bed every night at Alan's age. Treatment's a good idea. D, a positive family history is not present in most children who wet the bed. And E, this was the multinational study, European study, commonest retort from GPs. Bedwetting's not a disease, shouldn't worry about it too much, and waiting a little bit longer will see things resolve. I'm not going to give you which is the best answer, because hopefully these slides are going to tell you. So if we take very good, large cross-sectional studies across very different cultures in the world, you can see that there's a very similar pattern amongst them all. High rates at 5 years of age, dropping away to adulthood, but not dropping away completely. I want you, just for my purposes, to look at about 7.5 years of age, where we have Holland Holland at about 7%, and the States and Sudan at 17%, because on this next slide, we've got a very large study from Hong Kong who actually divided the wetting up into severe every night, moderate 3 to 6 times a week, and mild less than 3 nights a week. And you can see that most of the fall off between 5 years of age and 10 years of age are in your mild and moderate group. But actually none of it ever goes away, and there's no significant change after 10 years of age. So actually there appears to be a difference between mild, moderate and severe wetting at night time. This came out in 2006. At the same time, ALSPAC, which is the A1 longitudinal study of parents and children, which is this very large longitudinal cohort in Bristol, 14,000 children born in 91, 92, followed up now to about 26 years of age. And luckily, they asked a lot of continence questions of these children. And actually, the most powerful data we have in the world today is from this cohort with regards to incontinence. This is what ALSPAC showed at 7.5 years of age, that there were quite a lot of children with some mild wetting once a week, and boys more common than girls. And actually the figures 17% and 9%, that kind of correlates very well with those cross-sectional population studies that I showed you in the beginning. If we look at wetting twice a week, it drops immediately, much less common, still more common in boys than girls. But here's the thing, and this is the group of children we normally see. We normally see children who are wetting every single night. Actually, at 7.5 years of age, there are very few wetting every single night, and there's very little difference between boys and girls. So immediately we're beginning to see that actually it's quite a heterogeneous group. ALSPAC allowed us to do one more thing, because it took the projection of each individual child and it's projected all the way through childhood. And that's allowed ALSPAC to group the children into different groups. And this shows a really interesting thing. This axis here shows you these are your odds of wetting. If your odds of wetting are 0, you're dry. If your odds of wetting are 1, they're very high. But actually along the bottom here, between 4.5 and 9.5 years of age, we've got 70% of kids who are dry. Then we get the wetters. So school entry here, we've got about 30% of kids still wetting the bed on school entry at 4.5 years of age. We've got some with extremely frequent wetting, and 2 of these groups are very lucky. They actually over time just spontaneously resolve. There's this unlucky group known as the persistent group, who make up about 8%, who just continue to wet. And there's this very interesting group in the middle here called the relapsing group, who start off not too bad, but then actually join the persistent group, so that by 9.5 years of age, this is the group that remain. And of those wetting to start with, at 4.5 years of age, 40% are still wetting at 9.5 or 10. In other words, about half grow out of their wetting when they enter school by about 10 years of age, but about 40%, 50% are still wetting at 9.5, 10 years of age, and that's the group that we need to target and to treat. What about older age groups? These are your odds ratios at 14 years of age and 19 years of age for day and nighttime wetting, daytime wetting only, and nighttime wetting only if you wet at 9.5 years of age. So if you were a baseline wetter at 9.5 years of age, your odds ratios at 14 years of age and 19 years of age are incredibly high. For any statisticians amongst you, these odds ratios, an odds ratio of 23 is just off the Geiger scale. So if you were wetting by day and by night at 9.5 years of age, you've got a 23-fold chance that you're going to be bedwetting at 14 years of age. The bottom line here is that if you're a wetter at 9.5 years of age, your chances of wetting later on in life are extremely high. So it appears, we know this from adult women studies as well, it appears that the underlying bladder dysfunction is something that you're potentially born with and continues into your adult life. And these are the children, of course, that we need to target. So going back to Alan, we're going to ask him about his wetting. Basically, his wetting is variable. He can wet in the first third of the night. His wetting can be single, just once a night. It can be multiple. There can be small amounts and large amounts. And basically, he's a chap who just can't wake up. So he can't wake to the alarm. When we talk about daytime lower urinary tract symptoms, we asked about frequency, urgency, any urge incontinence, if there's any abnormalities of his stream, any urinary tract infections, and none are reported. And in terms of practical issues, they have a good nighttime regime. He remembers to wee before bed. His last drink is at least 2 hours before bed. They use nappies to contain the wetting. Bathroom accessibility is good. In terms of Alan's motivation, he is becoming a bit disheartened, and mother's very worried about the social consequences. And that's a very common scenario. Okay. I want you now, just as your baseline, to classify this enuresis and to think about what are the underlying contributors in Alan, because basically he's failed the first two basic treatments, enuresis and the alarm, and the contributors are going to help us define further treatment for him. So we all know what bedwetting is. It's variously defined by the ICCS and DSM, and you need a minimum of 1 episode a month for 3 months at least. What you might not know is that we now classify enuresis into monosymptomatic and non-monosymptomatic. What we mean by monosymptomatic is that when you screen for daytime lower urinary tract symptoms, there aren't any. It's just the one symptom of incontinence at nighttime. And at 7.5 years of age, 2/3 of children fall into this category, with only 1/3 having daytime symptoms. This swaps around by the teenagers. So if you ask a teenager, 2/3 of them will have lower urinary tract symptoms and only 1/3 don't. Primary and secondary are classification systems that you're aware of. So primary, the child's always been wet. Secondary, the child should have been dry for a minimum of 6 months. And just beware there, lots of children I see classified as secondary are in fact primary, because what you find is that the mother's actually been lifting them. Mother's been waking and taking them to the toilet, and that's how come they were dry. And again, a new classification, infrequent wetting, less than 4 times a week, and frequent wetting, more than 4 nights of the week. And this has consequences for treatment and how easy it is to treat. Just thinking about underlying pathophysiology, so sorry, just to go back to Alan, certainly he is a primary wetter. It's been there all his life. He's wetting every single night, so he's a primary frequent. And he doesn't report any lower urinary tract symptoms. So you would classify him as a primary, frequent, non-monosymptomatic lower nocturnal enuresis. Underlying causes. So again, I would ask you to do a show of hands at this point in time. But the underlying cause, I would ask you to pick one. The underlying cause common to all enuretics being developmental delay, emotional and psychological issues, lack of vasopressin release, bladder overactivity, or inability to wake to the need to void. The following slide is a slide that basically illustrates the underlying causes of enuresis, and this is a very useful one to take away with you. This is what I explain to all of my children and all of my adults, and it's really pretty basic. So basically, if you wet the bed, even if you take sensible precautions before sleep, sometime during the night, your bladder needs to void. And in fact, it's fairly safe to say that across the entire population of children, teenagers, and adults, 30% of bladders need to wee during the night. Only 70% can actually make it through the night without weeing. So when your bladder needs to wee in the middle of the night, the first thing that happens is it sends a message to your brain, oi, I need a wee, just like it does in the day. And your brain then responds in one of two ways. It either wakes, in which case you get up and go and wee and you have nocturia, or you can't wake, your brain doesn't have this capacity to wake, and you end up wetting the bed. And of course, this is the symptom that is very disturbing for children, but actually nocturia can be very disturbing as well for some children and also for adults. And interestingly, we know from Alsbach, who happened to ask this question, that at 7.5 years of age, 20%, 1 in 5 kids actually wakes up regularly to go and wee. And that way they keep dry. Whereas we know that at 7.5 years of age, only 0.2, 0.3% of kids wet the bed every night. So actually this is a fairly normal response, and this would be the pathological response. The treatment that we use for trying to encourage children to wake and to listen to the message between their bladders and their brain at nighttime is the Enuresis alarm, and that establishes the link and hopefully helps the child to wake and go to the toilet. What are the reasons why 30% of bladders can't actually hold and store urine during the night? Why can't they get through the night without needing a wee? Well, the first reason, of course, is nocturnal polyurea. As we go to sleep, our brains produce two messengers. One is melatonin, that puts us to sleep, and the other is vasopressin, which goes to the kidneys and says to the kidneys, slow down, please produce less wee. We have to get through 10 hours of the night of sleep without weeing. And if you don't produce enough vasopressin, you get nocturnal polyurea and the bladder capacity is exceeded and you need a wee. This doesn't present, of course, with daytime urinary symptoms, so it's called monosymptomatic nocturnal enuresis. And of course, the treatment for nocturnal polyurea is desmopressin, which is the chemical analog of vasopressin. The other reason that your bladder might need a wee in the night is if your bladder is just small, it's on the small side and actually can't, its storage capacity is diminished, can't get through the night. And there are two reasons why you may have a small bladder. One is just constitutional. The size of your bladder is distributed about the mean, and there's no actual bladder pathology. And you would have monosymptomatic nocturnal enuresis. And the other is that you've got an overactive bladder, which is actual bladder dysfunction, and you will have daytime urinary symptoms, and that is non-monosymptomatic nocturnal enuresis. And we actually treat both with bladder training by day to stretch the bladder. The best treatment for a constitutionally small bladder is the alarm, and for bladder overactivity is anticholinergics. So that's sort of bedwetting in a nutshell, and I go through the underlying causes with the child and the family after the history and get them to establish what they think the underlying ones are and therefore what the treatment is. Just some pointers on your history about wakeability. That's fairly logical. You can ask them about lots of things in terms of what will wake them. The coldness of cold wee, loud noises, parties, alarms, bad dreams, and some children just can't wake to anything. The clue to lack of vasopressin release is a large wet within 2 hours, usually within 2 to 3 hours after going to sleep, the first third of the night. So that kind of suggests that that's lack of vasopressin release. And your clue for overactive bladder, of course, is your daytime symptoms of urgency, frequency, urge incontinence, a small bladder capacity on your bladder diary, small voided volumes, a child that basically is always going to the toilet. And at nighttime, they often wake multiply, and the patches can be both small and large. Alan has no comorbidities, so we don't need to treat any of these issues. Constipation would be important to treat. UTI needs management in its own right. Emotional behavioural issues, we definitely see more enuresis in children with emotional behavioural issues, including ADHD and autism. That doesn't mean to say we ignore the enuresis. We support the emotional behavioural issues and we treat the enuresis as if as you would normally. Examination, urine MCS, all those things are entirely normal in Alan. And these are the consequences of him not being able to be dry. So the question is, what would you do with Alan now? So this is where we normally have a dialogue. I don't know if anyone wants to put some suggestions on the chat. I can have a look at those, but I'm going to press on because time-wise, yep, I'm halfway through already. So if we think about treatment for bedwetting, the NICE guidelines tell you that your first line treatment, you do all the informing, educating, no blame, good general measures about drinking during the day and voiding before bed, etc., etc. And we're very good at giving all of that advice and supporting all of that. When it comes to specific treatments, your first line treatment is the alarm and desmo, and of course these have both failed in Alan. I just want to quickly whiz through those first line treatments. Both the alarm and desmo have grade 1A evidence. The alarm, of course, is an operant conditioner. It basically is a sensor that goes in the pants and is attached to an alarm system. It can also be a sheet on the bed attached to a loud ringing alarm. And the theory is that as soon as urine hits the sensor, the alarm goes off. Everyone hopes and prays that the child wakes up. The child then has to get up out of bed and go to the toilet. The child very, very quickly works out that this is a really, really stupid system because, number one, he has to wet for it to work. Children are only wetting once a month or 2 times a week. It doesn't work very well because you need lots of practice with this every night. At the same time, if you are wetting multiply, wetting 3 times a night, you tune out to this alarm very quickly. It just becomes too onerous. So child learns this is stupid because I've got to wait, I've got to do the nasty deed for it to actually work. Number 2, everyone knows I can't wake up very well, so that by the time I wake up, it's all gone in the bed. Why would I bother to get out of bed and go to the toilet at this point in time? And of course, the answer is you've just got to practice waking and going to the toilet. And hopefully, if you can do this every single night for about 3 weeks, your bladder and your brain finally start talking to each other. And as soon as that bladder says at night, I'm going to wee, your brain picks it up, controls it. Oh, no, you don't. Child gets out of bed and goes to the toilet to wee. And they often actually learn to sleep through without doing that. But you can appreciate that this is a lot of work at night time. This takes a very motivated child because the child's got to do it themselves. And it takes a tolerant and supportive family. So those are the features that you have to be sure of before you recommend an alarm. That A, you've got this tolerant, supportive family, you've got a motivated child, and they really understand how this alarm is going to work. What about desmo? 2 more different treatments you couldn't wish to dream up. This one is literally you just pop, either swallow a tablet or pop a melt underneath the tongue just before bed. You've obeyed the strict fluid restriction rules of nothing to drink a minimum of an hour before and no drinking through the night. So make quite sure that that's happening. And basically you just cross your fingers, go to bed and hope that you wake up dry in the morning. Because what it does is you get a reduction in the amount of urine produced at night and you hope it can fit in the bladder. It's licensed for use for the long term. It's recommended every 3 months, if it's successful, so if the child gets to dry, every 3 months, just stop the treatment for a week at a convenient time to have a look to see if the child can actually do it on their own. If the child relapses, restart and run it again for another 3 months with another trial further down the line. The observed wisdom is that this is just patching over the problem and not curing it. Actually, long-term studies have shown that actually you do better on desmopressin in the long term than not. So there is some sense in some way that it is actually training the systems to become dry. We're not sure exactly how that happens. To improve your desmopressin efficacy, you can actually give the medication 1 hour before sleep, which means your last drink is now 2 hours before sleep. And make sure that meals are not within 2 hours of bed. Snacking and meals 2 hours within bed can increase your solid load and increase your urine production, and also reduce the efficacy of the tablet. Also, a structured dose-dependent withdrawal has been shown to be more useful than just stopping altogether. More recently, it's been shown that there's a gender difference with desmopressin response. Females respond better than males. And pharmacokinetically, we might be underdosing on the melt. Okay, so we're going back to Alan. Just remember, he's failed the alarm and he's failed desmopressin. And one of the things I would ask Alan to do is to do a bladder diary. Because now I'm beginning to think, I wonder whether there isn't some underlying bladder problems with Alan. So I ask him for 2 days to record every drink he has so I can see what his drinking pattern is like. And I ask him to record every time he has a wee, how much he voids when he wees, and how urgently he needed it for 2 days. And I know that a child's expected bladder capacity is age in years plus 1 times 30 mils. Once you hit 13 years of age, you reach an adult bladder capacity, which is somewhere between 400 and 600 mils. Recall that Alan is 10, so you'll be able to work out that his expected bladder capacity is 330 mils. And the other thing is your normal voiding frequency from toilet training age to adulthood is somewhere between 4 and 7 times a day. And when you wee, basically, you don't want any more than 10 mils left behind if you are 7 to 12 years of age or above. So if we look at Alan's diary, his voiding frequency is 10 times a day. Actually, that's slightly higher than normal. And the other thing is that his maximum voided volume is 194 mils, whereas for his age, we would, he's 11, isn't he, not 10. So his expected bladder capacity is 360. So you can see that actually his bladder capacity is smaller, quite a bit smaller than expected. And it looks like that his bladder capacity is playing a part. This is his bowel diary, and he opens his bowels four times in the week, passing fairly normal stool, and this doesn't actually constitute a strict diagnosis of constipation. So we know that Alan has got some bladder capacity issues. The other thing that's useful to measure is how much urine he's producing overnight. Very easy to do. You just weigh the nappy, subtract the dry weight, and remember the first wee of the morning. And Alan's smallest overnight urinary volume is 190 mils, and his largest is 385. We know that his bladder capacity is only in the region of 190, although it should be much more towards this kind of region. And we know that the definition of nocturnal polyurea for Alan's age group is greater than about, I actually can't see the screen here, but it's greater than 460 mils, greater than 130% of expected bladder capacity. So actually, he doesn't have nocturnal polyurea, but he does have evidence of a small bladder capacity contributing to his nighttime wetting. So what would we recommend now? We would go on to second line treatment. Desmopressin and an anticholinergic. This is a very powerful combination. Just desmopressin taken at night time, and an anticholinergic, I prefer tolterodine because it lasts for the same duration of time as the desmopressin, 8 to 10 hours. And basically the desmo reduces how much urine is produced at night time, and the tolterodine makes your bladder bigger. And they only are present at night. You get very low side effects, and it works extremely well. What was the outcome in Alan? When we tried that, we added 2 milligrams of tolterodine to the desmo. Unfortunately, no change. So now I'm going more into bladder work. I'm now looking at how we investigate small bladders. And one of the things that's really useful to do is uroflowmetry, just to check that this, particularly in a boy, that this bladder is not obstructed anyway. And you can see that he produces these beautiful flows, very high, nice flow rates, tower-shaped uroflows, classic of small overactive bladders. And his residual urines are within the normal range. So what I did with Alan then was I tried TENS machine, which makes bladders bigger, and sulfonacin, which is a more effective anticholinergic, which lasts for 24 hours. So just to remind you about the treatment, second line treatment would be anticholinergic and desmopressin. This is also a very powerful combination. You've got your forest plots here in terms of how well they work. And sadly, unfortunately, neither of those worked either. We're now going well into bladder work and what we did with Alan then, but it's just to show you. Alan is now 12 years of age. All of that other stuff has failed. We do invasive urodynamics. We place a urethral catheter, and we actually look to see what this detrusor muscle, what are the pressures in this detrusor during storage. And you can see here, I haven't got time to go through all these traces, but this bladder is doing spontaneous, uninhibited contractions. This is a massively high one. This is what happens with detrusor overactivity, overactive bladder. This is his pelvic floor responding by tightening and holding on. And basically, so that's his bladder overactivity. This boy, this study was done whilst he was taking sulfonacin, an anticholinergic. So it shows you that he's got anticholinergic resistant bladder overactivity. And before, we didn't used to have anything to offer these children, but we do now. We can offer them mirabegron, which is a new beta-3 agonist. We can offer them Botox. And we discussed this with Alan and his mum. They were happy to try mirabegron. Both of these treatments are unlicensed. And on mirabegron and desmopressin alone, he was dry 5 nights out of 7. And when we combined mirabegron with sulfonacin, he was dry 7 nights out of 7. So I think the reason I've dragged you through that whole thing is just to show you there are ways and means of getting these children dry. For any child over 10 years of age wetting their bed every single night, chances are you've got all 3 causes of wetting. He can't wake, he's got polyuria, and he's got some bladder dysfunction. And those all need investigating and following up, basically. And this was his void. His bladder capacity on mirabegron and sulfonacin went, you recall previously, from 194 to 522, well within the normal range for a teenager, with a beautiful flow and complete emptying. So that was a really nice outcome for Alan after very many years. Just very quickly, anticholinergics block the cholinergic pathway, which causes bladder contraction, and this new beta-3 pathway with this new medication, mirabegron, stimulates beta-3 receptors, which relax the bladder. So you can try either or. Mirabegron is not licensed for use in children, but we use it in our bladder clinic a lot. And of course, when you use the combination and you stimulate both pathways, you get very good effect. This is another similar 11-year-old boy. I want to show you something very important. This was his uroflow. So if you've got a boy with very resistant bedwetting, please remember, get a uroflow. His uroflow was completely obstructed. You can see that. That's a very obstructed uroflow. And when we did his urodynamics, lots of bladder overactivity, but an extremely obstructed voiding phase. This is voiding phase, very high detrusor pressures, pathetic flow. This is his urinary flow along here. And this was his fluoroscopy, and you can see basically he's got posterior urethral valves. And we probably pick up 6 or 7 boys a year presenting with fairly bog standard wetting that actually have obstructed outflow. And as you know, posterior urethral valves can have significant effects on upper tracts, and you need to identify them. The other group you get are the 12-year-olds, fundamentally, just to go through this very quickly, with ADHD, and actually they respond beautifully to imipramine, which is a very old-fashioned treatment, but actually has an evidence base for working. So that, in a nutshell, basically, is enuresis, underlying causes, and treatments. I now want to whiz through daytime wetting. I've only got 15 minutes left. When it comes to daytime wetting, you've basically got several causes. This is the one that is you're going to see 3/4 of the time. This is a storage phase problem where you get those uninhibited contractions of the detrusor during storage, which make you urgent, frequent, and wet. And dysfunctional voiding, where when you void, your sphincter doesn't relax properly, and actually you obstruct your bladder, and you get secondary bladder overactivity and poor emptying, incomplete emptying, urinary tract infections, reflux, and lots of comorbidity. Underactive bladders is when the bladders become overstretched and it just can't get the wee out anymore. And then there are other causes. I'm not going to go through epidemiology. Suffice to say that based on this ALSPAC data, we know that 14% of children on school entry wet by day. And here are the lucky 50% that grow out of it by 9 years of age. And here are the unlucky 50% that are still wetting at 9 years of age and have a good chance of going on to wet into teenagehood with symptoms in adulthood. So bladder overactivity, basically urgency is your key symptom. That is a sudden onset of a desperate need to wee, and if the child doesn't have a strong pelvic floor, they will leak. They often have enuresis, they have frequency, and they have holding maneuvers or posture. Their streams are extremely strong, gushing, very short, with very high flow rates. And on Bladder Diary, you get these very small bladder capacities. Here's a Bladder Diary with loads of weeing, lots of urinary frequency and lots of wetting, very classic of bladder overactivity. Here the uroflows, they're tower-shaped, very high flow rate. These are small, bossy, overactive bladders. The layman calls this kind of bladder a weak bladder because the assumption is that there's something weak that allows the leaks to come out. In fact, bladder overactivity is completely the opposite. The detrusor muscle is incredibly strong, and so is the pelvic floor because it becomes very good at holding. So just a quick, some tips on asking about wetting. On history, when do your wee accidents happen? If they occur after voiding with the sensation of needing a void, that probably means incomplete bladder emptying. If they occur after voiding without any sensation, just a dribbling sensation, that means usually that the urines come out, some's gone up into the vagina during weeing, and then you get up, walk away, and all that urine dribbles out of the vagina into the knickers, and that's called vaginal reflux. And you correct that with putting your legs wide apart when you wee and coughing into the tissue after weeing. That corrects that. What about with distraction? This is the classic boy on his daydreaming or on his Nintendo, and you can see that the boy has needed a wee for 2 or 3 hours. Finally, bladders don't burst, they wee, and he starts to wet, and that's voiding postponement. And that is a behavioral problem, not a functional problem. There is this wetting that occurs with laughter. Actually, the commonest cause of wetting with laughter is bladder overactivity, but you do get a few children that only wet with giggle, not laughter, not polite laughter, giggling only, and the whole bladder goes. And that is it's very rare, and we think it relates to frontal cortex inhibition problems, because actually the treatment is methylphenidate, Ritalin, which responds very well to. With activity, coughing, sneezing, jumping on a trampoline, stress urinary incontinence, extremely rare in children, slightly more common in cystic fibrosis because of the coughing, and now becoming more common in teenagers because of obesity. You must ask about your urinary stream, because that's where you're going to pick up your dysfunctional voiders. And of course, urine stream shouldn't be stop-start, shouldn't be dribbling or spraying. You should never need to strain when you pass urine. Here are red flags for daytime urinary symptoms. Continuous urinary leakage suggests anatomical problems. Maternal gestational diabetes, I always ask this. Sacral dysgenesis, caudal regression, we get about 4 of these a year. Base of the spine, very important, always check that for spinal dysraphism. And obstructed stream, extremely important. So always flip your child over because you do want to have a look at their backs to make sure that the lumbosacral spine is normal, there's no spinal dysraphism. I haven't got time to go through this, but this is a classic girl with signs and symptoms of bladder overactivity. This is her Bladder Diary, and basically her fluid intake is good, her urinary frequency is high, and her maximum voided volume is about 270 mils, which is low. When we look at her bowel diary, she's not strictly constipated. She's basically got daytime wetting, and she wakes up at night to wee on most nights, and some nights she doesn't quite get there. We did an ultrasound. I always do an ultrasound in clinic, and the first thing I see is this rectum pushing in on this bladder and measuring 5 centimeters across. The upper range of normal is 3 centimeters. And the first thing I ask this girl is, can you feel that you need a poo right now? To which she replies, no. And that immediately tells me this girl has got actually quite an issue with her bowel, even though it looks normal on the diary. She says type 4, type 5. Actually, you've got to ask her, what size are those poos? These are poos with a huge girth, and they irritate the bladder. So that's the first thing to sort out. We do a symptom severity score on her. We do some uroflows on her. She's got these sky-high uroflows. And our diagnosis is going to be bladder overactivity. She wants to know what her chances of wetting into adulthood are. She's got a high chance of continuing to have problems unless she goes for treatment. And this would be your treatment pyramid for bladder overactivity: urotherapy, then an anticholinergic or a TENS machine, then another anticholinergic with TENS, then potentially mirabegron or Botox. And this is exactly the pathway that an adult treatment pathway would be followed. Suffice to say, the bladder bowel dysfunction goes together, and that moves us very quickly on to the bowel. I've only got 7 minutes. Interestingly, constipation and soiling is actually not half as common as wetting, but interestingly, you're probably more likely to see constipators and soilers, because whilst there are no sequelae for urinary tract infections, the kidneys, etc., etc., socially this is so difficult to manage and so unacceptable to mothers and school, with huge social consequences for the child. So just a quick reminder about the bowel, because it's a pretty simple algorithm, a bit like the bladder. The bowel is not a storage organ. The bowel is a transit organ, and as is the rectum. And again, you've got the clue in the shape. This is a tube-like organ. It doesn't look like in any way that it stores. And actually, this picture is incorrect. There should be no stool here, because if there is stool in the rectum, you should have sensation of that. You should know that you need a poo, and you should feel pretty uncomfortable until you go and download it all and you're back to normal. So one of the issues is rectal sensation. Sensation in the rectum is really important. Sensation at the right volume, so that as soon as there is any extension of this rectum, there's feedback to the brain that makes you feel uncomfortable, and you get that lovely feeling of emptiness once it's gone. The problem with constipation, which can either be idiopathic, it's just there from the word go, or it's a learned behavior where the external sphincter starts to withhold, is that the rectum starts to become a storage organ. This means that the rectum has to distend. This means that sensation goes down, tone goes down, and the rectum becomes bigger and floppier, and you get this overflow leakage. Every time some wind comes down and the wind is let out, you get dirty farts. And basically, these children tell you, I can't feel that I need a poo. I don't know when I need a poo. I can't feel it, and I don't know that I'm having the accidents. And this drives the parents mad, and they're absolutely right. So the way that you have to think about it, just to talk through this a little bit more, is first and foremost colonic motility. Your whole colon. Is your colon actually delivering the goods to the rectum in a timely manner so that the stool is the right consistency? That's number one. And you can think about things like sweet corn. Do you ever see sweet corn in the stool? Eat some sweet corn and see how long it takes to get through. Because the normal transit time for a bowel is 24 hours. You are allowed 8 hours, so you are allowed to poo 3 times a day, and you are allowed to poo every 48 hours. But outside of that, your colonic transit time is either too fast or too slow. Then you have to think of the rectum. Is it the right capacity? The right capacity means that it's got correct sensation, and has it got good evacuation? Does it let all of the poo out once it's there, or does it just let one out and then the sensation's gone, so the child doesn't let the rest out? These are things that you know very well from the red flags, etc. These are general measures: diet, hydration, and activity, very important for good. And of course, toileting. Lots of children just resist bowel opening and they just refuse to toilet. That's often the first thing you have to deal with. So in terms of management, there's education, explanation, toilet training, fluids, blah, 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 all that stuff. A lot of time and effort goes into this. Laxatives are the next thing. And of course, we have 2 kinds of laxatives. The one is a softener, Movicol, and the others are stimulants. And the way I think about it is, if the poo is hard, give a softener. If the poo is massive, in other words, you've got a big dilated colon that stores and holds too much, you need to increase the tone in that colon. you need to decrease the size of that colon, and you need to increase the evacuatory efficiency of that colon. And that's going to need a stimulant laxative. So the mistake that I often see people making is giving children with massive rectums Movicol. All that does is change the massive cannonballs into massive cowpats. And actually, to be honest with you, cannonballs can be easier to cope with than cowpats. So you can use Movicol to soften poo, but you need a stimulant laxative to actually move things through. Stimulants are Senna and sodium picosulfate. Sodium picosulfate works directly. Senna needs activation by the colon. Senna tends to be slightly gentler than the sodium picosulfate. So you can take your pick of those two. But often those children that are struggling, you need both a softener and a stimulant. And often the children just end up using stimulants because once a day the stimulant goes in, sets to that rectum, squeeze and push, and it all comes out. You've got a treatment pyramid here. Neuromodulation we use, but there are very few centres that do, just specialist centres. But don't forget PR medication. You know, you get some teenage boys who open their bowels once a month from prolonged withholding, significant dysfunction now of their rectums and their colons. They will not take laxatives because they never know when it's going to hit the bottom and they can have accidents. So they just point blank refuse. Offer them little microlax enemas that they can do themselves. They're brilliant. You just lubricate them, pop them in the rectum, push, and the rectum pushes and delivers within a few minutes. So that it allows them to choose when they're going to poo at a time that suits them, and they can stimulate it. They get good evacuation, good feeling, and often just use those as required. I often have boys who are very happy with this and just leave clinic. But more and more, we're also using the retrograde colonic enemas, the bowel washout systems. And finally, some children actually need surgery and an antegrade colonic enema. But there's a whole range, of course, of this. Okay, I'm not going to go through the 10s. And there's loads of really good assessment papers now. These are mostly from the International Children's Continence Society into how to treat all of these things. And Eric is an excellent source of information, as well as the Continence Foundation of Australia. Okay, and that's me done. I hope that was useful, and it was a bit of a whistle-stop tour, but just to realize that there is a whole lot of science behind bladders and bowels these days. Any questions? Okay, and if I can encourage you all to do bladder and bowel work, it's really, really rewarding. All right, thanks a lot. I'm going to sign off. Katie, will you close the meeting down, or do I? I think I will close the meeting down if you're all happy. Okay, all right.